Really appreciate everyone joining. Today we're discussing liver disease and whole body MRI as it pertains to the Prenuvo scan. I'm Eric Chafe. I'm the head of sales for Prenuvo. It's my pleasure to be hosting this webinar today with two awesome people. Number one being the famous Dr. Vikash Modi, our director of Preventive Medicine, as well as Dr. Grant Goldsberry, one of our head radiologists. As an overview, we are a dedicated whole body MRI screening service. We currently have 12 locations across North America. We have multiple opening towards the end of this year, and as well as a lot more happening in 2025. Our primary focus is on the patient-centered radiology practice and strictly looking at routine longitudinal whole body MRI screening as a proactive approach to healthcare. Our team has played a pivotal role in the technical advancements of MRI application for general whole body screening, plus the clinical translations of these techniques. We've been doing this for 15 plus years, optimizing our services along the way. What's important to us is the continuous iterative feedback. QI further benefited from our patient-centered approach. One key thing for us, and we know this is important for all of you and your patients, is really creating a warm, welcoming environment. We know that with MRI, with any type of imaging, there can be some level of anxiety, and our belief is that the kind of the more traditional cold clinical setting isn't as conducive to really creating that top-notch patient experience. As soon as you walk in, you're greeted by two friendly concierge staff at the front. The clinic is warm, it's welcoming. As for the actual MRI, we use a wide bore, open-ended MRI, memory foam mattress, Netflix on the screen. We do everything we can to really ease the anxiety of getting imaging done and make the experience as enjoyable as possible. In fact, I just had my second scan in Chicago last week, and my only complaint was that it finished before my show finished. So and I'm a little bit claustrophobic, so it was really, it's really a top-of-the-line experience. But I'm not going to continue to talk on too much longer. I would love for you to hear from the stars of the show, quite frankly. And at this point, I'm happy to pass it over to Dr. Vikash Modi.
Thank you, Eric. We actually chose this topic this month because July 28th is World Hepatitis Day in honor of the physician, Dr. Bloomberg, who discovered hepatitis B back in 1967. So we are honoring him by discussing and exploring liver diseases today. So what I want to do is talk about why we should be screening for liver diseases in the first place. As Dr. Bloomberg knew then and what we know now, that it's important to remember that the liver plays all these crucial functions, such as breaking down drugs and alcohol and helping to promote protein productions that are vital for things like blood clotting. And of course, the role it plays in digestion of fats and cholesterol and glucose, as well as iron metabolism. So conversely, if those are all the things the liver is good at helping us manage, then diseases of the liver are really going to be critical to surveillance and to manage as best we can. Things that can cause liver diseases are ranging from, as we know, viruses, like Dr. Bloomberg discovered hepatitis B, medications and drugs, so things that we actually prescribe or that patients are taking. Of course, everyone is familiar with the concept of alcohol consumption causing liver damage, and now ever more present is the unhealthy diet that is causing such sort of catastrophic widespread disease of livers. Throughout the course of this discussion, we're going to be touching on elements of risk and detection of diseases, and I'm going to use a case study to sort of illustrate the idea of scanning and screening, but then also of how to manage these early signs of liver disease that we are hoping to get ahead of. So I'm going to just go through this case study quickly. We've got a 42-year-old Asian male who happens to be a practicing surgeon. This is a real Prenuvo patient, by the way, who presented to our clinics for a whole body MRI based really off of a family history of diabetes, heart disease, and then most recently his mother had experienced elevated CPKs and liver enzymes. So he had a kind of very specific concern for his own liver health. and he was familiar with our scan's ability to screen and detect for those. So this patient's past medical history, he is slightly overweight with a BMI of 28, waist circumference in the mid-30s there, 36. He has a history of hyperlipidemia, hypertriglyceridemia, for which he is taking medication, the Lopid 600 twice a day. He's got a history of neck arthritis, for which he's taking ibuprofen versus Tylenol every other day. So pretty regular use of these medications. And then a history of depression, for which he's taking Wellbutrin 300 once a day. Things he's not treating are an elevated A1C. I think he noted somewhere around the early 5.7, 5.8 range, but he had no real surgical history to discuss. Social history, really nothing majorly contributory aside from diet. Alcoholic drinks were maybe 3 to 5 per week. Monogamous sexual partner with no history of STDs or hepatitis. He's getting screened regularly as part of his credentialing from his physician job. He does exercise regularly, but he admittedly has sort of poor dietary compliance. So, we kind of asked for vaccination history at Prenuvo and found out that he has all vaccines are up to date, so no real risk for hepatitis infection there. And his COVID boosters are biannually. And just of note, this patient in particular was a non-converter for hepatitis B antibodies. So we documented that even though he is non-reactive on antibodies, we are considering him fully vaccinated. So as a clinician, you're probably already kind of formulating your next steps. But I would like to kind of shed light on sort of an approach that we can take here in the 21st century using various technologies that we now have. The place to start is just by, again, understanding the liver's importance. Right now, the liver cancers are the 6th most common cause of cancer-related deaths in the United States, and I think it's sort of like the 4th or the 5th in the world. And cases have actually tripled since 1980, so we're not actually getting better at detecting or treating liver cancer at this point, given the increasing rate of disease and death. So the therapies of treatment have improved survival rates, but again, the caseload is what's increasing. Just out of interest, the top 5 cancer deaths are currently lung, colorectal, pancreatic, breast, and prostate. So if you're thinking through your preventative service task force list, most of those are things that we currently have guidelines for. Pancreatic sort of falls off that list, and now liver are 2 things that we still need to get better at screening. The idea here is that the most common type of liver cancer is hepatocellular carcinoma. It makes up about 80 to 90% of all cases, so it will end up being the type of cancer that I'll kind of focus in on when I discuss how to screen and manage early risk factors. Other types of liver cancer are cholangiocarcinoma, that's the bile duct, neuroendocrine tumors, and then hepatic adenomas are very, very small minorities of the cases. So again, hepatocellular carcinoma is really the premier type that we are hoping to address today. Liver cancer screening indications are, liver cancer screening is currently only recommended for adults at high risk because they have an increased risk of the disease itself. So again, things that we will consider high risk will be on the next slide. But the idea here is that there's no screening recommendations for adults of average risk, which is sort of this new category that we need to really define and try to get better at detecting diseases. So again, increased risk doesn't mean liver cancer is a certainty, but it should lead to regular screening exams and detecting cancer in early stages. So again, early detection is going to be the best opportunity we have for successful treatment. Those risk factors that increase liver cancer are including gender. So males unfortunately have a 3 times higher risk than females. Of course, history of smoking and alcohol makes lots of sense. Ethnicity unfortunately plays a role as well. And so I've ranked them from highest risk to lower risks. And so Asian Americans and Hispanic and Latino American Indians fall into the higher risk categories there. Then, of course, things that we may or may not be kind of collecting in our patient history would be the hepatitis infections. If we're detecting the primary biliary cirrhosis, that's a huge risk factor that we should try and catch early. The inherited metabolic diseases, a little bit difficult to detect later on in life, but hopefully earlier in life they're detectable. And then autoimmune hepatitis, aflatoxin exposure, cirrhosis is a major one. And then the most common, newest one is now the metabolic dysfunction-associated steatotic liver disease. That's a mouthful. They've just rebranded at NAFLD to this MASLD diagnosis. We probably all trained under the diagnosis of NASH, so non-alcoholic steatohepatitis. So change the brand all you want to. The point here is that this disease is growing. It is becoming a fundamental part of the diseases that are afflicting our patient panels, and it's one now that we need to be much more aggressive about tackling. So back to our case study, our patient completed their scan, which revealed the presence of moderate fatty liver disease. So I'm going to let Dr. Goldsberry just comment on the imaging here if he's got a moment for us.
Thanks, Dr. Modi. So just the upper screen has just a few selected images from both our MRI protocol and then also one of the more common screening techniques that are used on MRIs and just the general MR population around the country as well. So the top two images, you can see one from a healthy liver and one from a fatty liver. One of the techniques that you can use for detection of fat in the liver is an in and out of phase sequence within MRI. So the top images on the screen are in phase imaging, and the bottom two images are from out of phase imaging. And if you look at the two images stacked one above and one below each other on the healthy liver side, you see that the liver parenchyma itself doesn't look dramatically different between those two images. And that's a liver that is not afflicted with fatty infiltration. If you look at the other two images on the fatty liver side, you see the top image has that kind of lighter gray tone to it. And then you look at the bottom image, and especially on the more inferior portion of the liver on that particular image, you see that it has a darker gray color to it. And that's kind of the hallmark of how you detect fatty infiltration of the liver. So the right image has fatty liver, the opposite image has the more normal image. The other two are just a color depiction of what the data is showing in those two images.
The labs that I've listed down below are now in addition to the results that we got from this patient's MRI. So just as a sort of collective view of the labs, essentially really nothing extraordinary in terms of disease screening for hepatitis. The patient's A1C was slightly elevated into a pre-diabetic category. And then if you're watching fasting insulin levels in patients at risk for diabetes, this patient's fasting insulin was elevated from what we would like to see. Cholesterol seemed reasonably managed considering he's on medication, but that poor diet is playing a role there on his elevated triglycerides. And then we're going to finally look at the transaminases. So liver enzymes, AST, ALT, not particularly elevated. Alk Phos, not particularly elevated. On the high end of normal, and that's something that we should be more sensitive to with patients who have these risk factors. But I actually had a FIB-4 score on this patient, and this patient's FIB-4 score fell into a sort of normal risk range. So again, based off of lab work, which most providers are going to be collecting on a regular basis, we've got a couple of metabolic risk factors. The disease really shows its face on the MRI. What I want to do here is discuss the kind of pathogenesis or progression of these liver diseases, starting from the level of fatty liver and then moving forward. So, liver cancers, including hepatocellular carcinoma, the one I'm going to focus on, again, accounting for a majority of the liver cancers that we are able to detect and treat. So the idea is that once you have fatty infiltration of a liver, we develop a fibrosis type process, so hence the FIB-4 score that I alluded to earlier. Once that liver damage is really taking place with fibrosis, the inflammation is going to start to sustain. And over time, chronic fatty liver disease, chronic fibrosis, is going to lead to an inflammation that is going to cause the cells to become scarred. And severely scarred hepatocytes are what we describe as cirrhosis. So at the point that we're now detecting cirrhosis, that means that the disease has progressed quite far. This is where things get really interesting. Damaged cirrhotic liver cells are now more prone to accumulated DNA mutations. That's going to interfere in the normal cell cycle, and these cells essentially become immortal. So we sort of understand that the immortality of these cells is the definition of a carcinoma, of a cancer. So we've now got dysplastic nodules. These nodules are not going to die. They're going to become proliferative, invasive, and they develop these new survival advantages on a cellular level. And this is the essence of hepatocellular carcinoma. Backtrack just a little bit. The modifiable risk factors are the best place for us to start as clinicians. Our first goal is to hammer these into our patients and to re-evaluate them on a regular basis, at least with their annual checkups, if not more regularly, once we've identified liver risk factors. So alcohol consumption, which is a major worldwide condition at this point. The worldwide decline is happening, but the U.S. is actually increasing its average alcohol consumption. So we're going the wrong way culturally here. Smoking tobacco is something that we need to, of course, always counsel. And then tackling these other conditions such as obesity, type 2 diabetes, and the untreated infectious hepatitis. This next slide sort of demonstrates what I mentioned there, that the worldwide consumption of alcohol may be decreasing, which is the top half of the graph, but the bottom half of the graph, which the United States falls into, is growing in average alcohol consumption, along with countries like the Congo and India. So in terms of health prevention, not great company to be in, unfortunately, the amount of money that this country is spending on healthcare, we really need to be hammering messages on obesity and alcohol consumption much harder. This next slide demonstrates the diabetes projections that right now worldwide we're going to see a significant increase over the next decade. Millions of cases in 2019 are going to project into 2030 and 2045 with these statistics on this graph shown. So again, we're looking at potentially 150% increase worldwide projections over the next 20 years. The concept now is great. We've identified risk factors. What can we do to actually screen our patients? From a non-imaging perspective, the best tools we currently have are physical examinations, in which we are feeling around on the liver and doing our percussive techniques that we learned in med school, right? We all still do that technique. We also are potentially screening for transaminases, and if we have someone at moderate risk, we may increase that frequency to every 6 months, and of course more frequently if we have other pertinent risk factors like alcohol consumption. And then the collecting a FIB-4 score is a really helpful scorecard now. The FIB-4 index, which is something you can actually order when you order your labs from Quest or LabCorp. They now have a modified CMP that includes a FIB-4 score at no additional cost to the patient. It just comes as a calculated number on the reports, and that's something that you can now use to track your patient's fibrosis score. And it's really a pretty easy calculation. It's your age multiplied by your AST divided by platelets by the square root of ALT. So, okay, complicated math. But the point is that the algorithm allows us to get that number generated automatically and be able to track that for our patients at risk. The last couple of screening tests here are your alpha-fetoprotein blood test and a liver ultrasound. That is recommended every 6 months for patients at high risk. That is the current gold standard. Again, my concept here, though, is to identify patients who might be at average risk. The next slide here will be just a quick review of what the med books showed us about liver disease. This is the signs and symptoms, what you're looking for on your exam. Hopefully we remember our caput de medusae, the anterior abdominal veins. Increased risk of bleeding and bruising. That's due to the hepatocytes failing to produce those critical clotting proteins. And then more common things that patients won't necessarily even report all the time, which is feeling full after meals, a feeling of pressure under the ribs, particularly the right side. And then more noticeable will be the ascites, when they start really having large abdominal swelling, jaundice, blood in the urine, and pain that radiates around the back to the shoulder. Lab studies with irregular results. So as you're doing your screening for these diseases, you'll be identifying their CBC, their metabolic panel, their clotting factors. Always keep screening for hepatitis B and C. That's not a one-time thing for patients at risk. And then irregular transaminases and FIB-4 score, as I mentioned earlier. Things that are maybe more subtle would be your elevated red blood cells. Erythrocytosis is actually a sign of liver failure, and that can result or cause someone to look red and flushed. Higher cholesterol levels despite diet That is, again, now a failure of hepatocytes. And then, of course, the alpha-fetoprotein. More, again, nuanced signs and symptoms would include your liver tumors that produce hormones. So, if you're very savvy, you'll catch the high blood calcium, the hypercalcemia, causing nausea, confusion, constipation, weakness. That's actually a late stage of the elevated AFP levels. And then low blood sugar. That's a really common one that we actually, I think, may overlook, is that significant episodes of hypoglycemia, which can cause fainting and fatigue, are due to the tumor's high metabolic needs, just consuming and churning through the patient's glucose and secreting hormones like IGF-2 and big IGF-2. Grant, would you be able to now take us now through the imaging options that are available for screening?
So I'll kind of touch on just the high points here. So again, we've kind of been talking about how do you screen patients in average risk. Again, most of the recommendations are for those patients in high risk population of patients. Ultrasound, as Dr. Modi mentioned, is really what is the mainstay for screening high-risk patients. There is, both your routine ultrasound and then also utilizing ultrasound with contrast, which is a bubble contrast. The bubble contrast is not widely available. It's a little bit more challenging to set up in most practices, so it's not really anything that's widely used. So majority of the screening is just a routine ultrasound examination. The obvious benefit, there's no radiation as compared to CT scans. The big downside is there's a relatively low sensitivity for picking up abnormalities. There's both, low sensitivity just because of the modality of ultrasound, and then also any type of ultrasound exam is always technologist dependent. So it's not quite as standardized as an MRI or CT where exam to exam you're getting very similar imaging. With ultrasound, it's dependent on the technologist performing the study. So that can also add in some variability to the detection rate. CT is generally a next step after an abnormality is picked up with ultrasound. Again, a contrast exam is going to be more sensitive and probably more specific as well. And you can also combine that with AFP testing to both bring up the sensitivity and specificity of the screening. Again, the big downside to any type of CT imaging is that it's a radiation-based exam. So doing a CT every 6 months for screening purposes is not ideal just because of the cumulative radiation exposure. Individual CT scans are of no real significance as far as the radiation dose, but it's an accumulated dose to the body over time. MRI is in general going to be your highest, both for specificity and sensitivity. There's benefits in that there's no radiation with an MRI exam. The downside is using gadolinium-based contrast within MRI. We know that does deposit in the human body over time. We don't know exactly what the outcomes are of that heavy metal deposition within the body, but obviously in the unknown setting, we prefer to not be using contrast if it's an option. Also, there's the expense of MRI and then just availability. MRI machines are exceedingly expensive. There's only a limited number of spots that you can place patients into for screening, and there's obviously competition with just other exams that are going to be performed on that MRI machine. So again, as Dr. Modi's kind of touched on, and I mentioned before, ultrasound is the gold standard. CT is going to be where you move to if an abnormality is detected. One of the newer modalities that's used in ultrasound now, again, this is primarily used in the higher risk rather than your average risk patient, is FibroScan. And ultrasound is based on kind of sound waves passing through the human body. FibroScan is able to detect kind of the speed of that sound wave moving through the liver. We mentioned in one of the other slides just kind of the pathogenesis of how cirrhosis forms in the body, and it's that fibrotic change that happens to the liver, and that fibrosis is going to change the speed of the ultrasound wave moving through the liver. So it's a way to grade the fibrosis of the liver without having to do a biopsy of the liver. And that's been typically the gold standard for deciding what stage of fibrosis is occurring in the body, is to actually take a tissue sample. If we can do it non-invasively, that's beneficial both from a cost perspective and just a risk perspective. Anytime you put a needle in the body, there are some types of bleeding risks and other complications that can occur. In general, there's a relatively limited research that's been performed on how diffusion-weighted imaging in an MRI scan compares to the traditional either ultrasound or CT or different types of screening. Diffusion imaging from a kind of a technical manner is really evaluating how freely water molecules move in the human body. So things such as tumors, other abnormalities. We also use diffusion-weighted imaging to detect strokes in the brain. It's basically trying to detect either an infarct, it's kind of some dying tissue, where tumors are more densely packed, filled with lots of cells. So both those instances change the way the water molecule moves in the body, and that can be an assistant to the radiologist on how we pick up abnormalities. So tumors, strokes are going to have restricted diffusion, and that's a way we can basically do, the way I typically explain it is it's a pseudo contrast. It's totally different than utilizing contrast, both on how it appears on imaging and just the physics behind it, but it's a way of picking up abnormalities without administering contrast. There's a couple of studies I'm going to touch on here. One directly compared diffusion imaging to ultrasound. In this particular exam, they actually had 100% sensitivity for picking up abnormalities with ultrasound. Real world, that's a very optimistic number. We're not going to achieve that in real world applications when you're evaluating the liver with ultrasound. Diffusion-weighted imaging had an 83% sensitivity in that particular study. The big benefit of diffusion over ultrasound, and this does translate into real-world imaging, is the false positive rates. Ultrasound's going to have significantly higher false positives, which is why we typically move on to CT or MRI as a secondary imaging modality after ultrasound. Another study compared how ultrasound, along with blood testing, compares. So if you combine ultrasound and the blood testing, you can increase the sensitivity, but also the false positive rate. So there are benefits in sensitivity, but also disadvantages in that you're going to have more patients called back for additional imaging for a false positive when that may not be necessary. Just looking at the benefits of diffusion imaging. So it's not just looking at the liver per se. In the Prenuvo world, we're actually doing a whole body examination. So we're looking from head to toe and attempting to see what abnormalities are detectable. So the diffusion techniques can be utilized not only for picking up liver abnormalities, but also other abnormalities that may occur in the human body. This particular example here has an adenoma that can occur in the adrenal gland. That's a non-malignant condition, but you can also utilize that in and out of phase imaging and the diffusion imaging to detect non-cancer abnormalities that may have clinical significance to the patient. It's also kind of the goal with our screening protocols is to detect things at the earliest stage, the most treatable stage. So obviously smaller is better, confined disease is better. So with whole body MRI, we want to detect abnormalities, particularly in the liver, but then also assess if you're picking up a later stage malignancy. Is it contained to the liver or is it potentially spread to other places in the body? Typically, we've had to use PET scanning, which is basically attaching a radiotracer to a glucose molecule for detecting, whether a cancer is confined to a particular body part or is it more metastatic. That has, significant costs associated with it, and it has the potential of detecting disease later in the process, less able to be treated. Now, these are several just real-world examples of what we're utilizing in Prenuvo scanning. So this is what a fatty liver looks like on an MRI examination. So if you're looking at the The image that's on the right-hand side of the screen here, you can see that it's a very dark color, and that's actually what a fatty liver appears like on an MRI image. So that lighter gray color is the in-phase imaging, and the black liver is the out-of-phase imaging. This is an example of severe fatty infiltration of the liver. So this is a patient that has a large amount of fat deposition in the liver. This is going to be your patients that have the highest risk of developing, moving on to fibrosis and potentially cirrhosis down the road. So you can, look at weight loss, medications, other processes that might be resulting in the fatty liver disease, and hopefully modify those up front so we don't progress to cirrhosis and other complications down the road. As I mentioned, you can use diffusion imaging for detecting things in the liver and outside of the liver. This is actually a liver malignancy example that was unfortunately just picked up on a screening examination. So you see the large, kind of that lighter gray color within the liver, and also on the opposite image here, that's the diffusion imaging. So you can see that in this particular example, the brighter areas where the restricted diffusion is occurring. In this particular example, that's not, you're going to detect this abnormality just with the more traditional MR imaging, but this is just an example of, if it was a smaller lesion, how the diffusion imaging can assist with detection of smaller lesions and also allow us to characterize them much easier than just with your more traditional MR imaging. Again, as we were mentioning before, we're detecting liver-based problems, but also other issues that may arise in the patient. This is an unfortunate case of a patient that had a widespread disease process that presented to us just with a screening protocol. You can again see diffusion imaging on the two outer images, and then the more conventional T2 imaging in the middle image. And you can see that there's mesenteric masses and also lesions involving the bones of the body. So this is an unfortunate case where the disease is widespread at this point, but it allows easier detection for the radiologist, easier characterization. So diffusion imaging it's a very powerful modality. And again, I kind of compared it to a pseudo-contrast. It's mechanistically, it's different. It's not contrast injected in the body and flowing through the body, but it's instead picking up the way those water molecules move within different tissue types within the body.
Thank you, Dr. Goldsberry. The understanding the imaging is incredibly important for anyone on the primary or preventive side, anyone who's kind of tracking these diseases. Of course, we think that the radiologists are able to help summarize what they see and put into these reports that we can really digest and translate to our patients. So I'm moving now into when we've got these results, when we've got these reports, like in the case of the screening MRI, or even if we identify risk factors on blood work, what are some early steps that we can take as clinicians? Significant actions that we routinely recommend are going to be getting the vaccines up to date and screening for the hepatitis C infection, as well as B, of course. And then strict elimination of alcohol, tobacco, exposure to hepatic toxic substances, like in our case patient, the heavier use of ibuprofen and Motrin daily. And then, nowadays we always have to be conscious of our patients taking steroids, with so many sort of retail services available for taking these medications, which are probably useful and helpful for so many patients. Understand that there are also some tests and surveillance and risk factors associated with the liver. And then dietary aflatoxins, which many of us probably aren't too familiar with, but the peanuts, wheat, soybeans, nuts, ground nuts, corn, and rice carry aflatoxins. So just counseling our patients to kind of reduce those in their diet is probably helpful for liver metabolism. And then the latest and greatest right now is just managing and potentially reversing type 2 diabetes with our patients, especially those with obesity and higher levels of visceral fat, which kind of maybe supports the idea of fatty liver disease. So, improving lean muscle, reducing visceral fat, these are easier said than done. A quick plug, not that they need it, but the GLP-1 class of drugs that's now become so prevalent is showing incredible results in the ability to reverse type 2 diabetes, obesity, and now fatty liver disease. So much so that I believe that they are now pursuing FDA indications for the treatment of fatty liver disease using medications like Ozempic and Mounjaro. The treatment options are becoming a little more proactive, and that's something that we really want to try and encourage with our patient population. So back to our case study patient, the one that I've been introducing throughout. So our 38-year-old surgeon, we've now diagnosed him with the MASLD diagnosis, along with the elevated A1C and hypertriglyceridemia. These interventions are kind of cobbled together between consultation that we gave the patient and then also what that patient did with their primary team. Their primary care physician was able to kind of work hand in glove with us to enact some of these recommendations and then implement their own recommendations. So we focused on nutrition. This patient now is going to be twice as adherent to their Mediterranean diet, low carb, low sugar, and they even went so far as to enable some dietary delivery services, some foods delivery services to help them really kind of stay consistent with their nutrition. The patient sort of engaged with an exercise program that kind of focused on muscle strengthening and along with cardiovascular exercise. As I identified earlier, a little bit of muscle strengthening can help improve insulin metabolism. And then last but not least, the semaglutide was prescribed. This patient actually met the risk factors for insurance coverage with BMI over 27, comorbidities of hyperlipidemia and A1C, and now fatty liver disease. So the patient was able to get started on those weekly injections and advance from 0.25 milligrams weekly to 1 milligram weekly over a 3-month period. We were able to follow up with this patient because this case was really so relevant, and we got really interesting response here. So on the follow-up evaluation, which was actually done through biomarkers rather than a repeat Prenuvo scan, the patient was able to get a fibro scan, the elasticity test, through their primary care physician, which had a score of 230 dB per M. That score actually falls into the low risk category. So we are now translating the MRI results showing steatohepatitis around stage 1. We've now regressed into stage 0 or grade 0 based off of the fibroscan. So that was promising development. Within the 6 months of getting these implementations of lifestyle modification and medication, we were able to see a significant reversal of biomarkers. So just to walk through some of those, body mass index dropped from 28 to 25. A1C dropped from 5.9 to 5.4, so now out of that pre-diabetic range. Lipids showed an LDL decrease and HDL increase, but most importantly was triglycerides for this patient. He was at 303 before, now down to 138 with the new treatment plan instituted. Liver enzymes, again, weren't dramatically elevated before, but you can now see them shifting to the right and showing that they're probably closer to a normalized levels. And then the FIB-4 score, again, not really significantly elevated before, but we did see an improvement on the follow-up scoring. So our patient was able to show significant improvements with lifestyle modifications, with a treatment plan that included medication, and we effectively have now reversed the fatty liver disease. But if you follow that pathogenesis slide, we've probably also significantly reduced this patient's potential risk of developing fibrosis, which left unchecked would lead to cirrhosis and eventual hepatocellular carcinoma as risks. So we don't know where that patient would have ended up, but what we know is that we have now greatly reduced that potential. And as a population risk, this is something that we must do. So just to finish up here, I just want to really leave us with this message that catching the disease in its early state is critical, that we are able to see a 34% survival rate in patients with stage 1 disease detected. But once we get to stage 2, 3, and 4, we see that rate dramatically drop. And now we're looking at 12% survival and 3% survival at stage 4. So catching early is the key. We don't currently have guidelines for average risk patients, but we at Prenuvo and with the complement of different medical testing are able to now detect these diseases in their early stages and potentially change the trajectory of our population risk. So that concludes our discussion today I appreciate everyone's attendance. And of course, we are available for questions through our contact information. Thank you very much.